All right, so welcome to Take Charge for October of 2018. I like to do these question and answer topics every now and then, and that's what we're going to be doing today. Everybody knows that I'm a big fan of education. The more we know about our health and what our cardiologists are telling us and what makes good heart healthy behaviors, the better we understand that, the better our outcomes are. And there's study after study that has shown that. So my goal for today is you guys are going to decide what we talk about, but what we want to try and do is ask questions, get answers so that you understand as much as possible, and then by understanding more, your outcomes will be better as well. Sounds good? Excellent. All right, so I don't have any slides. I've got a whiteboard. I've got my nice booming voice. That's what we're going to go with. So we'll start off. Anybody have any questions? Linda.
Hi, Rob. It's always wonderful to have you as your speaker, and that's why we're all here, because we love you.
Great.
I have a question. You know, we've all had heart issues, and there's a whole bunch of vaccines out there that are being promoted. There's the flu vaccine, there's the Shingrix, you know, for shingles, and there's 5 or 6 other vaccines there.
Yep.
And I'm concerned, you know, when people are saying you have to get this vaccine, not necessarily my GP or my doctors, but friends and family. Oh, you've got to get this vaccine. It's so important. You've got to get the Shingrix. You've got to get your flu vaccine and all of that. And as you know, people with heart issues, which vaccine should we absolutely get, be careful about, or negative, not at all?
So good question. We're coming into flu season, right? And of course, there's a big push to try and get all these vaccines. Are they good, safe for heart patients? What should we get? What should we not get? So we know that as we get older, happens to all of us, if we're lucky, because if you're not getting older, it's a problem, right? So as we get older, we're a little bit more sensitive, we're more frail, and some of these infections, as we get a little bit older, can be very, very dangerous, and a lot of people die on a yearly basis from infections like the flu. So doing everything you possibly can to avoid getting sick is definitely going to be good. There's all the common practices that you want to do. The biggest thing, hand hygiene. Right? There's so many people roaming around. Making sure that you practice good hand hygiene is something that you definitely want to do. Vaccines, should you be looking to go those? So when they take a look at vaccines, they take a look at big studies, big trials. Generally speaking, with fixed populations, the studies show, for example, with the flu vaccine, if you're a cardiac patient, if you've got any kind of chronic condition, if you're over 65 years of age, odds are you're better off by getting the flu vaccine. You're less likely to get sick. If you do get sick, it'll be a little bit milder. And then bad stuff, death, mortality is less likely to happen. All right, so we've got general policies. Which ones does that apply to? Well, I definitely know the flu. We push that one here, and we're just starting to say it in the classes as well. Everybody should go and get their flu shot. The pneumonia vaccine ties into that one as well. Our messaging with pneumonia is you should talk to your doctor to see if it's appropriate in your condition. Same thing with the shingles vaccine as well. I actually had a patient last year who got shingles. He lost the hearing in his ear.
I heard some terrible stories.
Right?
About that.
Shingles is a terrible infection. So too is the flu. The flu does kill people. It really does. People don't think about it, it kills people. But shingles is a virus that many people have in their body. Herpes zoster, it's from chicken pox. A lot of people have it, and it just lays dormant in your nerves for a very, very long period of time. Until something happens to really get you weak, tired, and stressed, your immune system gets suppressed, and then this virus comes out in the nerve roots and cause a lot of horrific pain, loss of vision, loss of hearing, a lot of problems. So that's another one that's actually quite reasonable. Probably best to talk to your family doctor, because as you said, we got a wide range of people here. Flu vaccine, I'm confident with that one. The other ones, I actually think there's a lot of merit in it, but I'd encourage you to talk to your doctor. I'll share a personal story. I just turned 50 over the summer. I'm going for my 5th-year physical. Thank you. I'm actually going to be asking about the shingles vaccine, because I've actually had shingles twice in my life. I've been lucky. It hasn't been very debilitating, but I've had it twice. As I get older, I don't want to get to the point where I do get it and I have vision or hearing loss or lots of pain. So that's a discussion I'll be having with my own family doctor.
When I talked to him, asked him about the effects of the shingles vaccine, because I thought when you were just saying that somebody lost their hearing
Yep.
from having shingles, well, I heard a lot worse from getting the shingles vaccine, and I was ready to get it.
Right.
And I
So-
thought, I also have heart issues.
So side effects from a lot of those virus, a lot of those vaccines and stuff like that. You really want to make sure that you talk to the physicians about that kind of stuff. A lot of the vaccines that they get will use basically dead viruses. So what happens is you get the virus, it goes into the body says, hey, this is a virus, I don't like it, develops antibodies to go and attack the virus and kill it and get rid of it, right? I believe with some of these viruses that are dead viruses, the viruses go in the body goes, oh my God, it's herpes zoster, that's the shingles, let's create the antibodies to attack and protect us. So they'll do that, but if the virus that they're injecting is dead, it's not going to cause an awful lot of side effects. Sometimes the suspension that they put the dead virus into can cause a little bit of a reaction, and some people can be sensitive to that. But there's a lot of misinformation out there around a lot of vaccines. I really do encourage you to talk to your doctors about it, because you're right, some of us do have really complicated cardiac stuff, and you need to make sure that you talk to a doctor who's familiar with your history to make sure that it's safe and appropriate for you. More often than not, it's the right thing to do, but I'm not going to go and say carte blanche, everybody do it. Flu vaccine is the one I'll push the strongest because we do that every year, but the other ones I think they're pretty important, but that should be with your family doctor. Okay?
And there, what I've been told, we have two strengths of flu vaccines.
Yes.
That should be noted. And
Yep.
what they're promoting, what I've been told, is that the stronger strengths is being recommended for people over 65.
So the comment is there's currently two different types of flu vaccine, kind of a regular strength one and an advanced flu vaccine. I actually just heard about that from a patient today, and the recommendation that, as far as your understanding, the higher risk populations, 65 plus, cardiac, should probably get the stronger one.
And I've actually checked this out.
Yep.
With the Sunnybrook
Yep.
people, and what I've been fed back was people with.
So this goes to the same kind of thing, right? All these kind of vaccines in a cardiac population or an older population with other health problems, a lot of comorbidities. It's good to do everything you can to stay healthy, good hand hygiene, vaccines where appropriate, but it's always best to go to the doctor and say, this is me. What's the best for me? Don't rely on media, friends, and what you've seen on the internet and stuff like that. Go to the physicians who are there to practice best evidence-based medicine. If they tell you to do something, they should be able, if they get pulled into a court of law and said, I said X, here's the proof behind why I said X. Okay? Frank, you had a question. Perfect. Yes.
Do you know, do they have the shingles vaccine for people who have lupus?
Do they have a shingles vaccine for people who have lupus? I have to apologize, I don't know. I don't have a good answer.
I had the shingles vaccine, and now they've come up with a new one where you have to have two.
That's correct.
Right.
Do I have to have that as well?
Yes.
This entire session is called Stump the Chump, and I'm being stumped an awful lot. So a new vaccine has come out, which is a couple of doses. Does that mean you need to have two?
Yes.
Once it, so all the hands going up. So what's the consensus here?
Okay, the original one
Yep.
apparently doesn't last forever.
Right.
The new one is supposed to be permanent. You won't need more, but you have to take 2 doses. You have to take
Perfect.
one, and then 6 months later another.
Okay, so that's fantastic, because the original one used to be you get it and then 10 years later you need a top up. So it sounds like the new one is one that you would get that would last for an awful lot longer. So this is another one where it sounds like that second one might be a good one to get, but maybe you don't need to get it now if you had the first one last year, because then it's going to last for a while.
It's 2 months, you get the first one, and then 2 to 6 months later.
But if you've already had one, you'll definitely. If you've already had one before the old one, you'll want to go to the family doctor and say, I had the old style vaccine, this new one is out, how do we go forward with this new one? Maybe you'll need to get it right away. Maybe they'll say there's enough protection that you can go for 3-4 years. But this is one where you want to have the discussion with the family doctor. Okay?
The old one was 50% effective.
Okay.
The new one is 85%.
There you go. So various effectivenesses with the vaccines. That's also true with the flu vaccine. With the flu, it varies an awful lot year to year. So when we give the flu vaccine, it's an educated guess. So we think these are the various strains of flu that are going to be going around. We think these are going to be the most common. That's what we'll vaccinate you with. Sometimes that educated guess is really, really good. Other years it's not so good. Okay?
Yes, if a person has been injected as a child for measles and chickenpox,
Yep.
does that mean that they'll never get shingles?
Oh boy, we're right on all this virus stuff. You know I'm an exercise guy, right? I'm an exercise guy. If you got the if you got vaccinated against chickenpox when you were young, does that mean you'll never get chickenpox? It decreases the odds that you would get chickenpox. I'm loath to say it'll never happen because we all know people that have gotten chickenpox multiple times and stuff like that. So I'd be loath to say it's never going to happen. I'd assume it's going to decrease the odds of it happening because you have the antibodies to fight off the virus already.
They'll never get the shingles?
So you've got, when you get the virus, you get the antibodies that should protect you against it. All right? The shingles is the same virus that's already existing in the body and it just kind of flares up. So I would hope not, but I don't have a great answer on that one. Please have an exercise question. Please.
I want to know
Yes.
how others
Yep.
and you are motivating ourselves to keep in our target heart range for the minimum of 15 minutes and really be in that target heart range.
Okay, so good question. How do you stay motivated to keep exercising at the right intensity? So I like that. This is one I can talk to with confidence. When we prescribe exercise, we just had a couple of physiotherapy students that just joined us, and I'm talking about exercise prescription. If we take a step back and we take a look at the prescription of exercise, there's kind of this pyramid model that I like to take a look at when I prescribe exercise, and it applies to everybody. All right, so we've got this pyramid model. It's got kind of 3 steps or 3 stages. Whenever someone comes to me and talks about exercise, the first thing that I try and do with them is establish a regular pattern of activity. Doesn't matter what they do, but just establish a pattern so that they're doing some kind of activity on a regular basis. Once they're being active on a regular basis, the next thing I'm going to try and do is I'm going to try and get them to take that activity and make them do more of it. This is what we call increasing the volume of exercise. Both of these things contribute to something called metabolic fitness or metabolic conditioning. So what does that mean? Keeping your blood pressure under control, lowering cholesterol, controlling blood sugar, helping with body composition, lowering blood pressure. We all recognize these. These are risk factors for heart disease. And you can improve on all of these things simply by doing a good volume of exercise. 30 minutes most days of the week will improve that dramatically. The third step is the most important step, and that's what your question's about. And this is the part that a lot of people forget about. And that's optimizing your intensity. That means exercising at a level that's hard enough to stress your cardiorespiratory system. You take a look in the medical literature, you see this acronym called CRF, cardiorespiratory fitness. And if you want to live a good long life, you want that CRF to be as high as possible. The only way to get that value up is to make sure that you're exercising hard enough.
And don't drink.
Hold on to the alcohol question. I'll come back to that one. All right? So optimizing intensity, how do we determine that here? What we end up doing is we have you have this cardiopulmonary assessment, this stress test. You guys know the drill. We put you on the treadmill downstairs or the bike, grab that tube in your mouth, and then you start exercising. It gets harder and faster, and eventually you get to the point where you just can't do any more. Okay? What that test lets us know is it lets us know how much oxygen-rich blood can you get from room air into your lungs, to your heart, delivered to the muscles. Right? And the more oxygen-rich blood, more oxygen you can get to the muscles, the fitter you are. So it's a good measure of your fitness level. All right? And then what we do is once we know what your maximum ability to deliver oxygen-rich blood is, we find activities that match that level. All right? And that's what we prescribe them. So how do you know if you're going hard enough to do this? Taking a look at how your breathing is going is one really, really good way. Right? This is something that we're pushing a little bit more. Is anyone familiar with the walk and talk test? Okay, so if I were to flip this to you, I'm going to pick on you a little bit. If I'm a new patient and I come in here and say, oh, that crazy guy Rob was talking about the walk and talk test, what does he mean? How would you explain it to a patient?
You have to be able to have a conversation with a person while you're walking.
Okay, so basically while you're walking, be able to have a comfortable conversation. And that's how we describe it to a lot of patients. I have a problem with that one now. I actually think that's probably not the best way to describe the walk and talk tests. So, well, yeah, 20 years ago when I was way a little whippersnapper, I've changed, I've grown. When we exercise, ideally we should be exercising at something called the anaerobic threshold. So what's the anaerobic threshold? When we do activity, our body requires oxygen-rich blood. The more activity we do, the more oxygen-rich blood we need. Eventually we're going to get to a point where we're doing more activity, we require more oxygen-rich blood than we can supply. Right? And if we keep going beyond that level, we go into this anaerobic energy system. All right? We produce lactic acid, our legs get all knotted up and tired, we start breathing really, really hard. We can only do that for a short period of time, and then our legs seize up and we have to stop. All right, so finding that level just below where we go anaerobic, that's the anaerobic thresholds. When you're doing your walk, if you can speak comfortably, you're below your anaerobic thresholds. All right? Because obviously you can talk, which uses more oxygen, and if you can talk comfortably, you're well below your anaerobic threshold. So ideally you want to be exercising at a point where you can have a reasonable conversation with the person that you're walking with, but if you're going blah, 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 blah nonstop, or singing, you're well below your anaerobic thresholds, and you're probably not going hard enough. All right, so that's something to keep in mind. We tell people, yeah, you got to be comfortable while you walk. That's selling out this optimizing intensity thing. How to stay motivated to stay there. Probably the simplest thing I would say for that is just to try and mix it up a little bit. So if you're always doing a walking program to get you into that level and you're just getting bored with it, you can try changing your walking routes. You can try and find ways to make the walking maybe a little bit harder. So look for hillier routes. So going up the hills is going to be a lot harder, so you walk a little bit slower, but as long as your breathing is right in that range, you're going to get the benefits. Changing the mode of exercise is a big one as well. You know, I always say, bless the heart, it's a wonderful organ, but it's not smart. All the heart knows is muscles move, send blood. So if you walk or you bike or you do the elliptical trainer or you swim, as long as you get your heart rate up to the same level and breathing to the same level, you get the same cardiac benefits. So trying different modes is another way to do it. Okay? Then the last thing I'll suggest, and this is something that we've had a couple of talks about in the last couple of years, is to try doing something called high intensity interval training. You knew that was coming, right? You knew that was coming.
But it's really hard, isn't it?
Yeah, it's really hard. Most of you guys are doing MICE. MICE stands for moderate intensity continuous exercise. You guys know the drill. you do the warm-up, you get your speeds, you do the cool down, you're done. That's how we've been prescribing exercise to cardiac patients forever. It works pretty good. It'll improve your fitness level anywhere from 10 to 20, 25%, depending on the studies that you take a look at. Do we want to improve our fitness level? Yeah. If you improve your fitness level, you're less likely to die. So that's a pretty good target for all of us to try and achieve. It's not the best way to improve your fitness level. High-intensity interval training can improve your fitness level anywhere from 15 to 20%. It's almost 50%, depending on the study. So your fitness level will be higher. You're even less likely to die. It's how athletes train. Athletes do high-intensity interval training because it is the best way to improve your fitness. For the longest time, though, we didn't want to do it in heart patients. We thought you guys were all nice, fragile porcelain dolls. We didn't want to break anybody. But as it turns out, there's a growing body of evidence that shows high-intensity interval training in most, not all, most cardiac patients is actually a safe thing to do. So how does it work? If mice is this warm-up, exercise, cool down, high intensity is warm-up, hard rests, hard rests, hard rests, hard rests, this kind of thing, and then a cool down. Okay? I talked about anaerobic thresholds. So you want to be going just at that level where you can walk for an extended period of time and talk but not be really short of breath. For mice, the anaerobic threshold is right at this level here. Okay? For high intensity interval training, the anaerobic threshold is here. So these hard segments are designed to make you short of breath. They're designed to make you work at a level that requires more oxygen than you can supply. That makes you short of breath because your body's craving this oxygen. It makes you dip into this anaerobic system, which causes lactic acid to build up in your legs. It only lasts for short periods of time. There's a whole bunch of different protocols. They range from about 20 to 30 seconds on the short end to 4-minute long intervals on the long ends. But this is something else that you can consider in terms of mixing it up. And this is a good way to keep your heart rate in that range. Now, having said that, being cardiac patients, don't go running out tonight, jump on the bike and try and do this on your own. Okay? It is harder work. You are cardiac patients. Safety is always the most important thing. All right? So this is the kind of thing, cover your ears at this point. If you're curious in high intensity interval training, we do graduate stress testing. If you're curious about it, come back, have a graduate stress test. Then we've got some good data, and we can use that data to prescribe this kind of thing in a safe, effective, very specific way. Okay?
Isn't the gap between the high and the rest different? Like, isn't the rest longer than the high?
So the question is, isn't the gap between the rest, the duration of the rest and the duration of the work different? So interestingly, there's about 1 million different ways to prescribe high-intensity interval training. There's a bunch of variances that they have. How long the work phase is, how long the rest phase is, that's one of them. They also have a lot of common features. So for many, not all, but many of these HIIT protocols, the work to rest ratio is quite similar. So for example, the protocol that we use here, the TRI protocol, 30 seconds hard, 30 seconds rest. Another popular protocol that we're using is called the 10x1. Minute hard, minute easy. The most commonly prescribed high-intensity interval training protocol in Europe is something called the Norwegian protocol, 4 minutes hard, 3 minutes easy. So there is a little variation, but not an awful lot. Okay? When people talk about different protocols in the recovery, you can do what's called an active recovery or a passive recovery. So an active recovery is you do the hard parts, and then on the recovery you just do it slowly. A passive recovery is you do the hard part, and on the recovery you just sit and do nothing. Studies seem to indicate that passive recovery actually lets you work harder. I hate passive recovery because I work with cardiac patients. So many of you guys are on medications to keep your blood pressure low. If you do hard work and then a passive recovery where you do nothing, blood pressures drop, you get lightheaded and dizzy, and it's just not fun. So I really, in my cardiac classes, really encourage an active recovery, not a passive one.
And you said that the fitness test that you can do here on an annual basis.
Yep.
If you ask, they'll prescribe.
If you ask, they will prescribe. So it's kind of funny. So you know the person you ask who gives you the results?
Yes.
Her name's Di. I don't know if you've met her.
Yes.
Wonderful lady. She's fantastic, right? She's sitting here in the back, which is one of the reasons I have to say this. So Di goes over all the test results with this, and Di knows that if anybody ever comes up on a graduate level and says, listen, I really want to do this high-intensity interval training, Di helps with a lot of the basic stuff, right? And then if there's anything really crazy and complex, she knows that I'm always around and I'm happy to talk about that stuff. So absolutely we can do that. And if we're going to give you any exercise advice, we really want to do it after one of those stress tests so we can prescribe safely. Okay?
You just mentioned about this aerobic threshold. Now, on the flip side, is there such thing as like the point where the balance, of the exercise and your heart condition? Like say in my case, right?
Yep.
I'm taking the medication which lower my
Heart rate, blood pressure.
Yeah.
Yep.
Well, every time when I take the blood pressure and then my doctor say it is normal, it's okay.
Good.
But then knowing that I'm taking the medication that lower my heart rate, which is like in the mid 50s.
Yep.
So when I do the exercise and naturally my heart rate will increase.
Goes up, yep.
Yeah. But then I'm given with the medication.
Yep.
And if I do the exercise and that increase my heart rate, so is it such a point where
It's a problem.
This is not what is intended.
Right.
And this is why we give you
The medications.
the medication.
So good question. Let's face it. Doctors give you guys a lot of drugs to slow your heart rate and slow your blood pressure down. Okay? Why do we do that? Well, I mean, if you break your leg, break your foot, we put you in a cast. You don't use your foot. It recovers, it heals up. We take the cast off and you're good to go. If you do something to your heart, you can't really put your heart in a cast, right? We can't tell you not to use your heart for 6 weeks. We just can't do that. So a lot of the medications that we give you are designed to let your heart rest and recover. So the amount of work that your heart does depends on how fast it goes and the pressure it's got to push against, blood pressure and heart rate. So the medication we give you lower the blood pressure and lower the heart rate so that it doesn't do as much work. And your comment is, so my doctor's giving me all these drugs to keep my blood pressure and my heart rate really low. And I go see this Yahoo Rob and he's giving me all the stuff to make my heart rate and blood pressure go up. Is that a bad thing? The body likes to stay in this homeostasis. It just likes to be nice and calm. It doesn't like to be disturbed. Exercise disturbs your body. All right? When you exercise, you put all these stressors and these strains on the body, and the body has to react to all these stressors and strains. Heart rate goes up, blood pressure goes up. It doesn't like that. So one of the things, the adaptations that the body will have to this stress is so next time you try and throw off this homeostasis, next time you exercise, your body will make changes so that the exercise doesn't bother it as much. So it'll make your heart stronger. It'll make the muscles stronger, the blood vessels stronger. So it doesn't respond to the exercise as much. And this is what contributes to improving your fitness and decreasing your risk. There is a trade-off though. We know putting a certain amount of stress on your hearts and your lungs and your body is a good thing. But too much is a problem. I read an interesting paper a little while ago, and it was like the Three Little Bears. It was called the Goldilocks Rule. And when you take a look at exercise and you look at volume or the amount of exercise and benefit, I might have these backwards, but it's a U-shaped curve. So if you don't do any exercise, we know that's bad for you, right? If you do too much exercise, as it turns out, that might be bad for you too, which is kind of addressing what you're asking. So what a lot of people now are doing research into master's level athletes. So you hear about the guy who's 65, 70 years old and he's riding a bike for 12, 14 hours a week. Well, as it turns out, that much stress, that much load on the heart for year after year after year actually starts to damage the heart to a degree. So that's why we're looking at this U-shaped curve for exercise, or the Goldilocks rule, right? Not too much, not too little, right in the middle. So to answer your question, yes, there is a time when too much exercise is going to be a bad thing. We're trying to figure out exactly what that amount is. I think I can safely say for pretty much everybody in this room, I don't think anybody's at that level. You're looking at the order of 12, 14, 15 hours of vigorous exercise a week, year after year after year. Right? Now, there might be a couple people, but I think generally we're all pretty good with that, right? Does that answer it?
Okay.
Yes?
Because I'm looking for, perhaps like a rule of thumb. If you are given that, the heart rate medication, then you shouldn't be looking for.
Scott, so you're looking for a rule of thumb that says if you got a medication that affects your heart rate, you need to modify the amount of exercise that you do. I don't think we're going to be able to say that. I think I can safely say that everybody in this room should be looking to get at least 150 minutes of exercise per week as a minimum. As much as up to 300 minutes per week of exercise is also been shown to be very, very beneficial. And in terms of the heart rates, or more importantly, the intensity or effort that you do, if you end up training right at your anaerobic thresholds, that's been associated with very, very good mortality benefits. In terms of giving you a heart rate, it's going to depend. I've got some people who exercise very well and their heart rate might go to 95. That's perfect for them. If they go up to 120, that's not good. I have other people in this room who go up to 140, 150, and that's great for them. If they're only at 90, it's not enough. So there's not going to be a rule of thumb that applies to all of us, because our cardiac history, our fitness, our medications, our response to those medications is going to be so varied. It's impossible to give a carte blanche other than exercise targets. 150 to 300 at your anaerobic threshold, feeling no pain is a good thing to do. Okay? Does age factor into any of this? So it's kind of interesting. One of my biggest beefs that I have with this kind of thing, that a lot of people who work in the industry see high-intensity interval training as a progression. So you start off walking nice and slow, walk a little bit farther, and then you got to run. And then once you're running for 4 miles, then we progress you to hits. That's not the case. High-intensity interval training should be considered for everybody, no matter what your fitness level, no matter what your age. Okay? So we're trying to recruit some people into a study that we're doing with the University of Ottawa called Prehab, where we're recruiting people who've been listed for cardiac transplantation. So they're on the list, they're just waiting for a phone call saying, hey, we have a heart, come on in. And these guys are going to be doing high-intensity interval training. All right, so these are the sickest of the sick cardiac patients. They're going to be doing hits. All right, and I've got another gentleman. I'll have to see how it goes. He's 92 years old. I'm thinking about maybe doing high-intensity interval training for him at 92. Okay. Now you got to remember, you know what HIIT's going to look like in him? He's going to be walking at a slow walk for his active recovery. And his high intensity is probably going to be about a 19, 20-minute mile. But that's, for him, that's working hard. It's going to make him short of breath. His legs are going to be sore. It's high intensity. It's just not what a lot of people think high intensity is. You got to get out of that cycle. Yeah.
If you've been told you have sleep apnea, you should get one of these breathing machines to work.
Yes. Yes.
Are those machines good or are they just a gimmick?
So good question. If you've been diagnosed with sleep apnea, and you've been told after being diagnosed with sleep apnea, should you get one of these machines to treat it? Is that a good thing or is that a gimmick? So let's go back. What is sleep apnea? Sleep apnea is a condition whereby you stop breathing at nights. Comes generally in two different kinds. There's obstructive sleep apnea. Obstructive sleep apnea is when you get a lot of tissue weight, and when you sleep, it kind of cuts off your windpipe, your tongue maybe falls into the back of your throat, and your throat's blocked. You just can't breathe. Okay, so obstructive sleep apnea is one type. The other sleep apnea is where your brain just forgets to tell your body to breathe. All right, and you'll just be sleeping, and then you might go 10, 15, 20, 30 seconds where you don't breathe. Same with the obstructive. And this might happen hundreds of times throughout the night. If you're not breathing, what happens to the oxygen content in your blood?
Goes down.
Yeah, it tanks. Well, we need a lot of oxygen in our blood for all the tissues in our body to function properly. And if you keep dropping the oxygen content, you're going to start causing a lot of problems. So it causes a lot of symptoms. With untreated sleep apnea, whether it's central or whether it's obstructive, you're tired. People always laugh when I see people nodding off in my lectures. One of the things that goes through my mind is, do they have sleep apnea? We know people that have got a history of heart failure and complex cardiac problems. The incidence of sleep apnea is higher. So that's what I look at. Daytime sleepiness is a big one. Trying to keep your weight off is a problem when you have untreated sleep apnea. Blood pressure starts getting really high with untreated sleep apnea. Heart arrhythmias increase with untreated sleep apnea. Risk of death, higher with untreated sleep apnea. So once you've been diagnosed and you know what it is, what's the treatment for it? Well, the problem with sleep apnea is the oxygen in your blood starts to drop. How are we going to keep that up? Well, if we just cram a hose in your mouth and just fill you full of oxygen all the time, it's not going to drop. That's on a very basic level what CPAP is. So it's one of these machines, and they've got this thing on the nose or on the mouth, and it continuously blows oxygen into your body so that the oxygen content in your blood does not drop. If you can prevent the oxygen content from dropping, blood pressure gets better, arrhythmia can start to resolve, energy level throughout the day gets better, becomes easier to maintain blood pressure, helps with weight loss, and your risk of death decreases as well. So it's absolutely not a gimmick. Very, very good thing to do. Sleep apnea is a well-known risk factor for heart disease that doesn't get treated or gets nearly as much attention as it should. So definitely not a gimmick. Now, CPAP is one of the treatments. If you have obstructive sleep apnea, there are other treatments that you can have as well. Obstructive sleep apnea is when stuff just kind of pushes down on your throat. If that's the situation, sometimes just a mouth guard to pull your jaw forward is enough to prevent the obstruction. You don't need the CPAP, the mouth guard would work. Some people, when they're flat on their back, brutal sleep apnea, snoring to wake the dead. Roll over on their side, they don't have all that tissue, it's much better. So you'll laugh, there are t-shirts out there with tennis balls sewn in the back. And you wear them to bed and the tennis ball is so uncomfortable you never lie on your back. They can work. So it depends on what kind of sleep apnea you have, and then there will be various options to treat it. Untreated sleep apnea is very dangerous. You want to try and make sure that you treat it. So definitely not a gimmick. Okay?
So about a year and a half ago, my cardiologist said that I'm doing fine and I don't need to see me.
Okay?
And I guess my question is, other than doing the annual stress test,
yes.
How does one know if you have a blockage or whatever without having
an angiogram? Yeah.
Well, what should one do other than the annual?
So good question. You have your cardiac events, you go through rehab, everything goes fantastic, you're doing everything you're supposed to. Cardiologist says, you're great, you're fantastic, I don't need to see you anymore, go away. What should you do to make sure that you don't have any further heart problems? Well, so there's all the lifestyle stuff, right? So you want to make sure that you're controlling all your risk factors as best as you can. You want to make sure you exercise. One of the reasons that I always push people and I say, do your exercise on a regular basis. Make sure that you measure your distance and your speed on a consistent basis. when you exercise, you're kind of giving yourself a mini stress test. Remember, the heart has got one job. All your heart has to do is deliver oxygen-rich blood to the cells in your body. All right? If you start having problems with your heart, it's not going to be able to do that job as well. You're not delivering oxygen-rich blood to the muscles as well. When you use the muscles, you'll feel that. You'll notice it that much more, especially if you do your exercise on a regular basis. Because if you always do 3 miles in 51 minutes, and then one day, you know, it's starting to take me 53, 54 minutes. I'm struggling to get the 3 miles in. The first flag that should be going up is, what's going on all of a sudden that I can't do what I should be able to do? And then that's a call to your doctor. And that's what I do. That's the big thing that we do here. If I ever call a cardiologist, I've got a patient. They normally do 2 miles in 34 minutes. They can't do it in under 40 anymore. That change in functional capacity is more often than not a direct problem associated with the heart. Cardiologists are on that so fast it's crazy. So make sure you exercise on a regular basis. Make sure you track it. When it gets harder, a flag should go up. And then other than that, if you take a look in the medical book and it says, how often should you stress test heart patients? There's no answer, right? Because we can show you 30-year-old heart patients we can show that are simple and straightforward. You can have an 85-year-old very complicated heart patient. Young guy every few years, you're probably okay. Older patient might be every 3 to 6 months. So there's no black and white answer. One of the reasons that we do yearly stress testing on our graduates is we think once a year it's probably a good idea to go and have someone look at your heart under stress, right? Having a resting cardiogram with your family doctor, all that says is when you're doing nothing, you're okay. All right? Your heart's got to get really, really bad to bother you when you're doing nothing. Have it checked while it's under stress. That's when you want to make sure it's working well. That kind of answer things. Your family doctor can set you up for testing on a regular basis. For most people, being managed by your family doctor is very, very reasonable. Doesn't have to be the cardiologist.
Can I ask a follow-up question?
Yep.
I saw my GP and I said to him, if I have a chest pain, I must call him or the cardiologist.
Yep.
And he said to me, you must use nitro and then you must take aspirin and you must call 911. So
that's a safe answer.
maybe talk to those last thing, what you would advise people.
So the question was, if I get chest pain, do I call the cardiologist, do I call the GP? And the GP says, if you get chest pain, you should take nitro, take aspirin, and call 911. What would I suggest? Okay, so what is angina? So angina is a symptom that's brought about by your heart when it's not getting all the oxygen-rich blood that it needs. Okay? If your heart's being starved of oxygen-rich blood, that's a bad thing and it'll complain. Cause a symptom called angina. Different people feel angina different ways. Okay, if I open up my textbook and I say, what's angina classically described at? A pain or a pressure in the left side of the chest, often radiating down the left arm or up the left side of the neck into the jaw. It's classical angina. There's a million different ways though people feel angina. Some people feel it as a pressure across the entire chest. Some people feel it as a squeezing in the throat, pain in the back, pain in the arms. There's a million different ways that people can feel angina. It can be a little disconcerting because now that I'm over 50, I get a lot of aches and pains. All right, what aches and pains are aches and pains and what aches and pains are angina? If you've ever had angina, odds are, if you have more heart problems down the road, the angina is going to feel the same. So if you had a heart attack, and when you had a heart attack, you had this terrible squeezing in your throat. You went to the hospital and said, oh yeah, that squeezing is your anginal pain. If you ever have heart problems again, you'll feel it the same way. 5 years down the road, you feel pain across the chest. It's a different pain, it's probably a different cause. So that's what angina is. If you get angina, what should you do about it? You need to get rid of angina as quickly as you possibly can. Because remember, angina is your heart saying, I'm struggling. I can't get all the oxygen I need. If you starve any cell in the body of oxygen for a long enough period of time, you will kill it. That's what a heart attack is. A heart attack is you killing off heart muscle by depriving it of oxygen-rich blood. So if you get anginal pain, what should you do? Well, if angina is brought about because my heart can't get all the oxygen it needs, well, let's make it so my heart doesn't need as much oxygen. right? So what's the first thing I do is I actually slow down. The more work you're doing, the more oxygen-rich blood you need. So if you're getting chest pain when you're moving around, come to a stop. By coming to a stop, I'm doing less work and then I require less oxygen-rich blood. Hopefully the anginal pain goes away, okay? If I come to a stop and the pain doesn't go away, I can't do less work than doing nothing, then the next thing you do is you take your nitroglycerin if you have it. Nitroglycerin is a type of medication that's called a vasodilator. What it does is it takes blood vessels, makes them bigger. That brings a lot more oxygen-rich blood. So if coming to a stop doesn't get rid of it, the next thing you do is you take your nitro. If 1 squirt of nitro doesn't get rid of the pain, 5 minutes later, second squirt. The second squirt doesn't do it, take the third squirt, and then you do want to call 911. Okay? There's a million different things that can cause chest pain. One of them is your hearts. But if you can't get rid of that chest pain on your own, it's important that you go to somebody who can. And that's what they'll do in the hospitals. Right? So if you go to a hospital in Toronto, they have something called the STEMI protocol. Stands for ST elevation MI. ST is part of the cardiogram. It's a part of the cardiogram that we focus on when we deal with blood flow. If it's elevated a lot of the time, that's a sign that your heart's having some acute problems. Okay? Elevation means it goes up. MI is a heart attack. Okay? If you have this, what they'll end up doing is they take you to a hospital, and right away they'll do an angiogram with an angioplasty. They'll go into the coronary arteries, they'll look to open up right away, usually within 100 minutes of calling 911. Okay? So if you do have anginal pain, you got to get rid of it. A lot of people say, I don't want to bother the doctor. I don't know if it was that 4th burrito I had or if it's a heart attack. Err on the side of caution. If you're cardiac patients and you get in chest pain, go to the hospital. No doctor, nobody should be saying you're wasting our time. Go there, have it ruled out so you know what the symptom is. If it turns out it is that 4th burrito, great. Take your Tums the next day, you know, you'll be fine. But if you end up waiting and thinking, I'll just wait through the night and if I still have the pain in the morning, then I'll go, remember you're killing off heart muscle through the nights. And while we can open up a blockage and decrease the size of the heart attack, decrease the damage that's done, dead heart muscle is dead heart muscle. We will not be able to bring that back. So it's important that you try and get that resolved right away. Does that help at all?
That's great. And so
Okay.
what about the aspirin?
So what about the aspirin? So the STEMI protocol gets you into the hospital and they put a stent, or they put in a catheter, they put a wire up, they find the blockage and they try and open it up. More often than not, they'll put a stent in there to keep it open. Before that, we used to use something called thrombolytic therapy. It's like liquid Drano for people. Most heart attacks occur when you have a narrowing and it ruptures, and then all the gunk in the blockage oozes out into the bloodstream and forms a big fat blood clot that acutely cuts off the flow of blood. A lot of people think, oh, I've got a blockage, it's 10%, it's 20, it's 40, 60, 80, 90, and then eventually when it gets to 100, it's a heart attack. It's usually a 60, 70, 80, 50, 40% blockage that bursts that causes it. Thrombolytic therapy goes to that blood clot that forms and it dissolves it. And by dissolving that blood clot, we can reestablish the flow of blood and it decreases the size of the heart attack. That's how we used to do it. Now we're opening up that blood clot with a stent. One of the reasons being is when we give you that thrombolytic therapy, when we dissolve that blood clot, it makes your blood really, really thin. What happens if I thin the blood in your head too much? We can cause a stroke. All right? So why aspirin? What do you think aspirin does to that blood clot? Dissolves it a little bit. So that's why the doctor would have told you take the aspirin and then call 911, because it'll dissolve the blood clot a little bit, and by dissolving the blood clot a little bit, you have a little bit more blood flow going through, and as you have a little bit more blood flow going through, it decreases the size of the heart attack.
I mean the chewable.
Okay.
Chewable.
Yeah, the chewable aspirin. Yeah. You had a question.
Regular stress test as opposed to nuclear stress test.
Good question. So the question is, what is the difference in the information you get from a regular stress test compared to a nuclear stress test? Okay, so with a regular stress test, you get a bunch of useful information. All right, so what do we get off of a regular stress test? Well, they put you on the treadmill or on a bike, and it gets progressively harder. Depending on how long you go, we can measure fitness, right? For every stage you go through a Bruce protocol, we know your fitness goes up, so we can measure your fitness. You can do the same on a nuclear test too, because they're both on the treadmill, right? We can measure your heart rates. So both tests will have cardiograms on there, and we can use that to see how high your heart rate goes up. We can use the cardiogram to take a look at heart rhythm. Okay, so we can do that as well. We can use the cardiogram to get a bit of a feel for if there's any blood flow problems. That's one ECG complex that represents one heartbeat. All these little different bumps and spikes are labeled different ways. P wave, Q wave, R wave. Anyone want to guess? Hey! There we go. So that's how the cardiogram is labeled. This line right here, that one right there is called the ST segment. That's the part of the cardiogram we take a look at for blood flow. So on a regular stress tests, if we see changes in the ST segment, that can be associated with blood flow problems. The cardiogram will start to look like this. That looks reasonable. So this is called ST segment depression for obvious reasons. All right? And when we see this, it's usually associated, it's usually a sign that you're having some blood flow problems. Okay? Not the most accurate, 85–90%, in and around there, but it's pretty good. In a nuclear scan, we do all of this stuff in a nuclear perfusion scan, but there's one other cool thing that we do. When you get to the end of the test and you can't go anymore, they take a radioactive dye, and they inject it into your bloodstream. There's different dyes that they can use. All right, they've all got different pros and cons, but they inject a radioactive dye, and then this radioactive dye binds to your blood. Everywhere that the blood goes, the dye goes with it. So you do the treadmill test, end of the test, they inject the dye, they take you off the table, take you off the treadmill, they lie on a table, and then this big camera scans over top of your chest. And what it does is it takes pictures of your heart from many, many, many different angles, and it's taking pictures of your heart specifically to see what part of your hearts have got that radioactive dye in it. Because remember, where the dye is, the blood is, all right? And then they assemble all these pictures and you get these wonderful images. And you might get something that looks like this. Looks basically like a donut. You get a good wheel. If that whole wheel is nice and glowing and bright, that means your entire heart is fully perfused of oxygen-rich blood. If you have a blood flow problem, part of the wheel will be missing. And then what we do is we say, we don't see that part of the circle. That means there's no radioactive dye in there, which means there's no blood in there. So that's how a perfusion scan would take a look at something like this. And this is a lot more accurate, probably about 90–95% of the time. So this is far more accurate in determining blood flow problems. Okay, now, when we do perfusion scans, we do exercise images, and then we also do pictures at rests. So if this is the picture that we see right at peak exercise, and you see the same thing at rests, what that means is at rest there's no blood flow problem. With exercise there is. Well, the artery that's supplying this part of the heart has got a blockage in it. Maybe we need to take a closer look with an angiogram, because that's the best test to see what's in there. But if we see at rests and exercise, they look exactly the same, what that usually means is that part of your heart has had a heart attack. Because if you have a heart attack, the heart muscle has died, it's replaced by scar tissue. Scar tissue doesn't uptake blood. So at rest, there will be no blood in the scar. With exercise, there will be no blood in the scar. Okay? So the other thing that we can do with this is a good way to take a look for blood flow problems. We can also see how risky a blockage might be. If I see only a tiny little sliver of that is missing, well, if there's a problem, you'll have a small heart attack, right? But if you have this test and half of it's missing, if that blockage ruptures, you're losing half your heart. So we can also see how much of the heart muscle is at risk with a nuclear scan. Does that answer your question? I like nuclear scans. I do.
Is that called a percentage?
Yeah, so a Persantine test, a cardiolite test, a nuclear perfusion scan. There's different dyes that they can inject. They can also do this kind of test at rest. So for example, if someone's got really, really bad knees, and they're thinking, I'll put you on a treadmill, but you can't go far on the treadmill, we can give you this Persantine dye, which mimics the effect of exercise and lets us know, without having to exercise, if you have any blood flow problems. That's with a Persantine. Yeah, that makes all the sense in the world. What causes an enlarged atrium? What's an atrium? We just renovated ours in the downstairs. Heart is a muscular organ, roughly the size of your fist. It's got 4 chambers. 2 chambers in the top are called the atria. That's the top. 2 chambers in the bottom are called the ventricles. The right is called the right. The left is called the left. So what will go and cause the right atrium to get a little bit larger? Usually the right atrium will get a little bit bigger if there's something that's affecting the flow of blood. So we've got valves between all the different chambers, right? Because you don't want the blood to flow in different directions. It's all got to travel smoothly through the heart. So we've got a valve between the right atrium and the right ventricle. If that valve starts getting a little old, a little weak, a little leaky, a little regurgitation we call, the right atrium is going to have to do an awful lot more work trying to push the blood through the valve into the right ventricle and out to the lungs. What happens to a muscle when it does a lot of work? It gets tired and it gets bigger. So that's one thing that could cause the right atrium to start getting a little bit larger. Right? The valve might not work. The other problem is if you have a problem with the right ventricle, because the blood goes from the right atrium to the right ventricle. The right ventricle gets a little bit weak. If it can't push the blood out to the lungs, well, the right atrium is going to be trying to push blood into this very full right ventricle. That's going to make it get a little bit bigger as well. Okay? We also have in our heart an electrical system. Okay, in the upper right atrium, we have a specialized clump of cells called the sinoatricular nodes. It's your heart's pacemaker. This generates electricity. The electricity goes from the SA node over the top part of the heart. Top part of the heart contracts, pushes blood into the bottom part of the heart. Between the top and the bottom, we have another specialized clump of cells called the AV node. It'll generate an electrical impulse, pass over the bottom part of the heart. Bottom part of the heart contracts, pushes blood out as well. Okay? In a perfect world, you get one electrical impulse that passes over the top, one that passes over the bottom. If your right atrium starts getting enlarged and big, starts swelling and getting larger, it takes those electrical wires, starts to kind of pull them apart. If you take those wires and you start to stretch them and pull them apart, they start to arc and misfire. And then instead of this beautiful one electrical impulse, you might get all these misfirings, and you can develop something called atrial fibrillation. One of the things that will cause atrial fibrillation is a right atrium that starts getting bigger and swollen. Okay? Does that answer it?
But is the left atrium the same?
So the left atrium would be the same kind of things. If you've got problems with the valves, problem with the left ventricle, you get the same kind of issues. Okay, I'm going to take 2 more. Yeah.
When we come into the program,
Yes.
say the diabetic program, and you do three stress tests, and then you come into the heart, you do 3 stress tests. And then when you come once a year, you have this accumulation of stress tests. Do you compare all these stress tests?
Yeah. So the question is, when you come into our program, whether it's the diabetes program or the cardiac program, they're all quite similar. We do stress testing on a regular basis at the start of the program, at the midpoint, and the discharge. And then once you graduate off the program, you are able to come back on a yearly basis, if you want to have graduate testing on a yearly basis. Do we compare them? Yeah, we take a look. Absolutely, especially the first 3, because when we do the midpoint, hopefully you're fitter than when you started. Likewise at the end, and then we use that information to change your exercise prescription. And then when you come back for your year physical, we'll take a look at the results of that and compare it to the end of your program to make sure you're still exercising appropriately and at a good level. So we do compare them one to the next, absolutely.
And do you once a year, would you prescribe exercise?
So once a year would we prescribe exercise. So once you have your test results, if it's in the program, your case manager should go over them with you. Once you're out of the program, you have the test, Di Nixon there in the back will usually give you a call, go over test results, ask you how your exercise program is going, and then based on the results of your test, if she thinks you need to modify the exercise, she will share that with you. Okay? One more way in the back.
How is the dilated left ventricle?
Can I explain a dilated left ventricle? Okay, we're going to end on a good one. All right. Here's our heart, our 4 chambers. Left ventricle. This is the most important pumping chamber in the hearts, right? Because the atria only push the blood down into the ventricles. They're attached, so it's not hard work. Right ventricle pushes blood to the lungs. Pretty darn close, not a lot of work. Left ventricle pushes blood to my fingertips and my toes. A lot of work, okay? Every time the left ventricle contracts, it pushes out about 60% of its content. So a good healthy left ventricle, about 60%. It's good to know, because a lot of people think, oh, my left ventricle is only 60%, that's horrible. No, that's normal. It's not going to be 100%. 100% the walls stick together, that's bad. About 60% is normal. If something damages the heart muscle, the muscle gets weaker. If the muscle gets weaker, it can't push out as much blood. So if you have a heart attack or a virus or a whole ton of different things that can weaken the hearts, if you damage this and it gets weaker, maybe now your heart can only push out 30% of its contents. So what happens at this point? Just for the sake of argument, let's assume the left ventricle can hold 100 units of blood. So 100 is what it can hold. A healthy left ventricle will squeeze out how many units? 60. In my example, the damaged one's only going to push out. It's not enough. So one of the things the heart says, well, my heart's damaged. I can't maybe fix that right now. What if I just get bigger? What if I get dilated and I go bigger, and now I can hold 200 units of blood? Well, 30% of 200 makes a lot of sense, right? Now my heart with the dilated left ventricle can push out all the blood that I need. Life is great. But not so much. Because remember, there's all these valves in the heart. The heart muscle can actually stretch. Valves not so much. As it dilates, you start pulling the valves apart. All right? We got an electrical system through the heart as well. Start pulling the electrical system out of whack, it doesn't work as well either. All right, so in a lot of cases, a dilated left ventricle is usually a coping mechanism of a heart that's gotten a little bit weak. Not always, but most commonly that's what will happen to get a left ventricle to dilate. Okay? To treat this, one of the medications that they'll give you, and many people have heard of Ramipril. Anybody here take Ramipril? Yeah, the one with the dilated left ventricle. What do we know Ramipril for? What does it do? Blood pressure? Yeah, blood pressure. So one of the other things that Ramipril does is it prevents this growing, this changing of shape. This is what we call negative remodeling. Your heart changing shape for bad reasons. Ramipril decreases the amount of negative remodeling that you would have. So people with dilated left ventricles are frequently on this medication, not because of blood pressure, because often their blood pressure is pretty low already. It's to prevent it from changing shape. Okay? I've gone for an hour and 15 minutes. So I am going to call it at this point, although I could keep talking for days. You guys know that. Okay? So we'll wrap it up. Thank you very much, everybody. Thank you, thank you. There we go. Excellent.